Hi everyone, welcome back to our ultimate seminar. Hope you enjoyed your Easter holidays. Marián Švajdler here speaking, and I've got only two cases today. The first one is tumor from the brain. It's supratentorial tumor in an 11-year-old girl. And that's all I know about the patient, and the case was sent with the correct diagnosis. I don't know if anyone wants to guess the diagnosis. It looks glial, and it shows this very typical distribution with these frequent perivascular pseudorosettes, and it's a typical picture of ependymoma, classical type. So there is no much nuclear atypia. It's very monotonous, and the cells are arranged more or less around these small vessels forming these ependymal pseudo rosettes. No true ependymal rosettes were found in this tumor, so we do not need true ependymal rosettes to make a diagnosis of ependymoma. So there are some mitotic figures, but not many. There is no necrosis, no microvascular proliferation. Just based on H&E or some basic immunohistochemical stains, you can make a diagnosis of ependymoma, supratentorial, classical type, and that's it. But nowadays, for a correct risk stratification and maybe for some management purposes, we need to do further molecular stratification. And the gold standard for ependymomas is methylation profiling. So they sent this case to do methylation profiling. But just before that, I will show you some immunos. They stained EMA, and ependymomas are known sometimes to have this very nice cytoplasmic dot-like expression of EMA. So these are some rudimentary luminal ependymal structures within the cytoplasm of these tumor cells. And if you have supratentorial ependymoma with such widespread EMA positivity, this can be a hint to one molecular subtype, and it's a hint for YAP1 rearranged ependymomas. But we also have another immunohistochemical stains which may be hints to molecular subclassification, and this is L1 CAM staining. It shows this diffuse positivity, and this is a hint to another molecular subclass. It was called RELA fusion positive. Nowadays it's ZFTA rearranged ependymoma. So we have performed methylation profiling anyway, and it came back as a SFTA or RELA fusion subtype of supratentorial ependymoma. This is quite important because these subgroup of ependymomas show worst prognosis regarding supratentorial ependymomas in children. And I will show you another immuno, and this is what I like to use when I'm making a diagnosis of ependymoma. This is SOX10 staining, and it's negative. Okay, so I always want to see SOX10 negativity in a case of ependymoma. If it's positive, then probably it's not ependymoma. We have published a paper several years ago as a first group, and nowadays I believe departments all over the world are using SOX10 negativity as marker of ependymoma. about 50% of astrocytomas can also be SOX10 negative. So it's not conclusive, but SOX10 positivity will rule out ependymoma quite confidently. Okay, so this is very good marker. So the diagnosis is supratentorial ependymoma, RELA fusion positive or ZFTA fusion positive. And my second case is another consult case. This is older gentleman with a retroperitoneal lesion. And probably just putting the slide into the microscope. Some of you may already know the diagnosis, but the location is very strange. Okay. So what you can see are these cytologically quite blunt, spindle or stellate shaped cells in the background, in a myxoid background, and having these curvilinear or chicken wire vasculature there. And another component you can see are some small adipocytes, maybe with some lipoblast, but we do not need lipoblast to have for a diagnosis of myxoid liposarcoma. But we are in the retroperitoneum, and this is quite strange for the diagnosis. So we basically need to do some stains, and I needed only one immunochemical stain. With this nuclear positivity, you've got DDIT3 immunoexpression. When you've got this morphology with this immuno, you don't need to perform molecular testing. That it's completely fine to do diagnosis of myxoid liposarcoma. But still, we are in the retroperitoneum, so this is a metastatic myxoid liposarcoma, and the original tumor was somewhere on distal extremity. Okay, they sent it for a consultation with correct diagnosis, but they were not able to confirm rearrangement using fish studies. Probably they had some technical difficulties. So nowadays we use only this immuno and very seldom molecular genetics. So my second case is metastatic myxoid liposarcoma into the retroperitoneal space.
You did just one immuno.
Yeah. Well, it's basically H&E diagnosis. Okay.
Yes.
Good afternoon, it's Michael Jr. here. I have an easy case to start with. It was a 47-year-old female, again a retroperitoneal nodule, and we had this tiny little piece of tissue, and again it's from retroperitoneum, not an old person, but 47, it's on the older side, let's say, and with this morphology where you have some adipose tissue, which doesn't seem that atypical, but on higher power can still locate some hyperchromatic nuclei. In other sections, I saw it. Yes, here. See here hyperchromatic nuclei of the adipocytes. Importantly, also see non-lipogenic areas. With this collagenous stroma, again with atypical hyperchromatic cells. So this is basically well-differentiated liposarcoma until proven otherwise. And if I had just the H&E, I would say most likely well-differentiated liposarcoma. Otherwise, you can do immunohistochemistry with MDM2 to confirm the MDM2 amplification here. The immunohistochemistry works usually relatively well, but it's not 100% reliable. So if I have so little tissue, I do just FISH, and MDM2 FISH was positive for amplification. Otherwise, we getting back to the case Marián showed, the second one, the myxoid liposarcoma, both tumors are liposarcomas. This is well differentiated liposarcoma. The previous one was myxoid liposarcoma, and people tend to think of, that there is a group of tumors called liposarcomas with few morphologic subtypes, perhaps, but it's actually not right. The tumors are completely different. You can basically think of the liposarcoma subtypes as you think of adenocarcinomas. You have pulmonary adenocarcinoma, pancreatic adenocarcinoma, colorectal adenocarcinoma. They all produce glandular structures. They may produce mucin, but it's about the only thing they have in common from pathological standpoint. And the same is with these liposarcomas. Well differentiated liposarcomas tend to occur in older patients, typically retroperitoneal structures or spermatic cord, mediastinum, and they have MDM2 amplification. In contrast, myxoid liposarcomas are more common in younger adults, most commonly in the thigh or some peripheral soft tissues. So when you see them in the retroperitoneum, as Marián showed, you can be almost certain it's metastasis. It's very rare to see.
The prognosis is completely different, and management differs for both.
The same for
Subtypes,
the same for other subtypes of liposarcoma, like pleomorphic liposarcoma. Again,
I believe there's some targeted treatment option for myxoid liposarcoma, and it's not for the differentiated or well differentiated.
There are, but it doesn't work very well, unfortunately. Yeah. Okay, so next case, somewhat more interesting. 69-year-old lady, tumor on the foot. So we see this cellular lesion already on this low power. You can see there are a lot of histiocytes, which are typical component for this tumor, these foamy cells, foamy histiocytes. They are not the neoplastic cell, but they are common there. So in some parts you have predominantly spindle cell morphology. You can notice this kind of hyperchromatic nuclei, atypical cells. In other parts, the cells were more epithelioid. Takes some time to find them. So these tumors typically show a mixture of epithelioid and spindle cells. More often, the epithelioid cells predominate, but here it's more on the spindle cell spectrum. And throughout the tumor, you can see these hyperchromatic atypical cells. And if I go in higher power, perhaps you can see this prominent eosinophilic cytoplasm. This is perhaps better. Prominent eosinophilic cytoplasm of the tumor cells, which has kind of like this, they call it glassy cytoplasm. I think it's pretty accurate. So if you see few of these tumors, you might think of it based on morphology. If you don't, you can do just your basic immunohistochemical panel. Again, cytokeratins, S100, CD34, desmin, EMA. That's what I tend to do for just random spindle cell lesions where I'm not sure what it is. And this is CD34. Almost all the cells are positive. So diffuse CD34 positivity. Usually a helpful marker for this tumor are cytokeratins, which tend to be focally positive in the tumor, such as here perhaps, also here. About 80% of these neoplasms are cytokeratin positive focally. And with this combination, kind of fits for a new or relatively new tumor entity. It's called superficial CD34 positive fibroblastic tumor. And for this tumor, we have a now quite specific antibody, SINCAM3 or CADM3. The names vary more. I think SINCAM3 is more commonly used, and it shows this diffuse, strong positivity, which is it's basically confirmatory test, because about half of these tumors, they have fusions, PRDM10 fusions with various fusion partners, but the other has no alterations or no known alterations. So the immuno is useful because it's positive in all tumors. Sometimes you can also find, they say 80%, my experience is worse, WT1 nuclear positivity, which is here shown, or the stain is here, but it's negative. So maybe we don't have the right clone, I don't know. So superficial CD34 positive fibroblastic tumor. Again, tumor occurring in peripheral soft tissues, typically in younger patients, younger adults or teenagers. Most common location is the thigh. This is another case. I don't know the location here, but again, some peripheral soft tissues. And the patient is a 30-year-old male. So you can see we are in soft tissues, unencapsulated, but relatively well circumscribed tumor. Very, very cellular, quite pleomorphic. Here in this case, composed more of epithelioid cells, and this is another example of the same tumor. This is just a case with like perfect morphology. This is a textbook example. One more important thing I forgot to mention: these tumors, they are very atypical, very pleomorphic, but they are generally indolent tumors. Out of like 40 cases published with follow-up, only one metastasized. And the clue that this is not a high-grade sarcoma is that you basically don't see, or rarely you find, mitotic activity. There are typically no necroses, and it's usually well circumscribed, sometimes even encapsulated. And in this area, you can see a very classic cytology, these epithelioid cells with glassy cytoplasm, very prominent eosinophilic cytoplasm, and prominent polymorphism. So superficial CD34 positive fibroblastic tumor. Here is the SYNCAM3 antibody. Again, nice, diffuse, strong positivity. If I showed you CD34, it would be the same. I'll just go on. In this case, actually had the PRDM10 fusion. So these tumors are very important because they were routinely classified as undifferentiated polymorphic sarcomas and treated as such, but these are again very indolent tumors. Don't call them sarcomas. Next case, 85-year-old female, tumor in the lumbar area. Very prominent cellularity, prominent vascular spaces, some myxoid areas, otherwise quite non-specific morphology. A lot of collagenous stroma in between the cells, and the cells are kind of ovoid, spindled, occasional mitosis, not extremely mitotically active. So this is another example of kind of, random spindle cell lesion, which is hard to call based on morphology. So again, I will do basic IHC panel, and from this, again, CD34, diffusely positive, and everything else from the basic panel is 100 cytokeratins, EMA, desmin, everything would be negative. But with this morphology, it's prominent vessels, kind of haphazard architecture. There is no special arrangement of the tumor cells. Prominent vasculature, a lot of collagenous stroma, and diffuse CD34 positivity. It's reasonable to add second round of IHC, and this is STAT6 antibody, which didn't work beautifully, but you can still see clear nuclear positivity for STAT6, so this is solitary fibrous tumor. Then for solitary fibrous tumors, we use this risk assessment score, similar to what we use for GISTs. So you basically have to open the WHO book and look for the criteria. It's based on age, size, number of mitotic figures, and the presence or absence of necrosis.
So SFT is a great mimicker. We saw cases with such epithelial morphology, gland-like
Yeah.
morphology. They may show lobular carcinoma-like arrangement of tumor cells and many others, clear cell morphology, and there's even the differentiated small cell variant of SFT. So if you are struggling with a soft tissue tumor, which is hard to classify, always remember SFT and do static staining.
Yeah. It's another great mimicker of anything. It can have any morphology basically. So this is a 19-year-old girl, tumor in the metaphysis of distal femur, and we received this very suboptimal, let's say, tissue, fragments of bone, some bone marrow, blood, and some fibrous tissue where occasionally you could track down some perhaps tumor cells that looks a little bit like lymphocytes. But there are better areas somewhere. Okay, here. So yeah, it's hard to tell apart from lymphocytic infiltration because it's crushed. But still we see relatively uniform round cells, and lymphoid markers were completely negative. There was some more tissue, I believe, somewhere, something a little better. But again, crushed. But it's a bone lesion, young girl, so you should, or young patient, so you should think of, and it's uniform small round cell morphology. Hematolymphoid markers are negative, so definitely you should think of
Ewing.
yes, small round cell tumors, and because the morphology is so uniform, it's kind of hard to tell for sure, but they basically look like perfect copies of each other, at least in the areas where it's not crushed. So it's reasonable to do CD99, which was diffusely membranously positive at the submitting institution, so I didn't repeat it. Another very useful marker is NKX22. It's a nuclear marker, very easy to read. So this is it, NKX22.
Excellent.
Beautiful, 100% of cells are positive. Even the cells which you didn't think are tumor cells are positive and are tumor cells. And this is PAX7, which is normally used as a skeletal muscle marker, but it also is positive in almost all Ewing sarcomas. So basically, only based on these three markers, I would be okay to call it, but based on the age of the patient, location, and so on. But they wanted molecular confirmation, and there is EWSR1 ERK fusion. NGS was possible actually from this bad material.
20 years ago, H&E and PAS staining was sufficient to do the diagnosis, but nowadays you have to confirm every case with molecular. Okay?
It was sufficient for
the only 2 cases 20 years ago. You have not to think about a lot of cases that we have that will show.
So
So
20 years
was
was
cancer,
sufficient.
no cancer.
We were diagnosed with other entities as Ewing sarcoma, and they found that the treatment is not working for the children. So
20 years ago it was sufficient, but the diagnosis was often wrong. So this is a 9-year-old boy, fever on his hand, on the finger. And we see a skin excision, normal epidermis, but right beneath the epidermis starts this spindle cell proliferation, where I believe many differential diagnoses are possible. Any suggestions? What do you would think of, or what stains you would do? Spindle cells quite uniform.
The Canadian case, yeah?
No. It's hard to see. This high magnification here is not very good, but the nuclei are, you can see them, but they are not super prominent. Another important thing is this. There is some pigment, most likely melanin pigment. I'm sorry? So here are some, I don't know if these are giant cells or not. Maybe just overlapping cells. But basically my differential was cellular blue nevus and clear cell sarcoma. Here it's much more cellular and nested. It's still not too atypical, but here at the bottom it's again somewhat crushed. And I wasn't sure if this is atypia or just artificial changes. So I started with basic immunohistochemistry, SOX10. All cells are SOX10 positive. HNB45 and tyrosinase were diffusely positive. I also did PRAME. I know PRAME isn't specific for melanoma, but it's actually a useful marker to exclude melanoma. When you are having a differential between melanoma and cellular blue nevus or clear cell sarcoma, because cellular blue nevus, clear cell sarcoma, also the malignant melanotic nerve sheath tumor, formerly called Salmatus schwannoma, they are always negative for PRAME, so we get PRAME negative. And I did EWSR1 fish, it was negative, and then I did small targeted DNA panel which found GNAQ mutation. So this is a cellular blue nevus. I think some dermatopathologists could call it based on morphology, but I don't see these tumors so often, so I felt better doing molecular. And actually, right at the same time, I had this other case, 54-year-old female tumor on the lower leg. It was sent as, or diagnosed as atypical fibrous histiocytoma, but they felt like they should send it for consultation. And I think it's good that they did. So again, cellular spindle cell lesion with this hyaline or fibrous septations. Nested arrangement in some areas. You see again kind of spindle cells, ovoid cells, but this time much more prominent nucleoli. Also the atypia is more significant here. Also in the previous case, what was missing was mitotic activity. I didn't see any mitosis in here. It's not super high, but you can still easily find mitosis, such as here in the center. So again here, I wasn't actually thinking here of cellular blue nevus, but I thought clear cell sarcoma or just some very uniform looking melanoma. So S100 diffusely positive, every cell is positive. SOX10 the same, HNB45. Again, not all cells, but most cells are positive. PRAME, again, very useful in this differential, I think. It's negative, so you can consider melanoma highly unlikely here. And I did EWSR1 fish, it was positive, so this is clear cell sarcoma of tendons and aponeuroses. So once more, this is kind of nested morphology. It's called clear cell sarcoma, but the cells are usually not clear. They are more commonly eosinophilic, such as here. All right. So this is a 46-year-old male who had a sarcoma diagnosed like a year or two ago on his femur, and now there is a suspicious recurrence or metastasis in the TH4 spine. Again, the tissue was not very nice to work with. These fragmented pieces of cartilage, where still, however, you can see it's not normal cartilage. This looks atypical. We have lacunae with multiple chondrocytes, prominent nucleoli. This looks maybe a little bit more cellular, but I'm not sure if this is part of the tumor, but this is certainly neoplastic cartilage, I would say.
Mm-hmm. It's necrotic.
Also necrotic.
Myxoid.
Oh yes, that's very important here. This myxoid change, you rarely, almost never see it in benign cartilage or benign cartilaginous tumors. And in another block, it's one again. More ugly-looking cartilage here. And there's something else. Okay, here. And then we have these fragments of high-grade malignant something, high-grade malignant neoplasm. But in combination with the atypical cartilage, I think you can basically think of malignant cartilaginous tumors or malignant bone-forming lesions with chondroblastic differentiation. So basically osteosarcomas with chondroblastic differentiations and various chondrosarcomas. Good thing is, I mean, the tissue is horrible. We didn't have any MRI, CT scans, no imaging, and we had just a history that the patient had a sarcoma on his femur, nothing else. But luckily, a large part, some 60-70%, I believe, of conventional chondrosarcomas have IDH1 mutations or IDH2 mutations. So I asked for targeted sequencing of IDH1 and IDH2, and there was IDH1 mutation. So this is basically dedifferentiated chondrosarcoma. Dedifferentiated because you have there those. Where was it? Here. Yeah. Whenever you have this basically undifferentiated pleomorphic sarcoma areas, this fat here, I mean, you can think of pleomorphic liposarcoma, but we are in the bone, so this is most likely remnants of bone marrow. And so you have undifferentiated pleomorphic sarcoma right next to malignant cartilage with IDH1 mutation. So the cartilage is chondrosarcoma, and this part is the dedifferentiated part of chondrosarcoma. It's whenever you have a dedifferentiation in chondrosarcoma, it's very prognostically bad for the patient. Okay, this was, I don't have the exact information, but it was adult person tumor on the finger. Again, very limited tissue. That's what we get in these days very often. So adult person tumor on the finger. You see here some kind of round ovoid cells, but also you see giant cells, perhaps. You can see it here in the center. The H&E is not perfect, but that's what we have. And then, besides the giant cells, there are some sclerotic stroma in between, and some kind of histiocytoid-looking cells. And because we are on the finger, adult person, we have giant cells in sclerotic stroma. I was thinking about Tenosynovial giant cell tumor, which is very common in this location with this morphology. So this is PU1, which is a very good histiocytic marker. It's very good because it's very sensitive, and it's also because it's nuclear. So you can very easily see which cells are positive and which not. And here you can see most cells are indeed positive for this marker, so they are most likely histiocytes. And well, in a normal microscope, you can see that there are some cells in between which are negative, and they are a little bit larger and epithelioid looking. Here's a good example. There's one here, for example. I think this is the one, this is the cell we are looking for. And when you think of Tenosynovial giant cell tumor, another good marker is clustering, which tends to stain the actual neoplastic cells because all histiocytes are basically just inflammatory admixture. The tumor cells are the larger epithelioid cells which stain with clustering, which is a marker of synoviocytes. And tenosynovial giant cell tumor is a tumor with synoviocytic differentiation. And these cells, which are positive here, there are not many, but those that are positive, I believe, are such as this one here. It's perfect. Are the malignant, not malignant, neoplastic synoviocytes. This is of course benign variant.
They also say this region may be Desmin positive.
Yeah, Desmin is occasionally positive in some 40% of cases, but only focally. It was negative here. Also,
my cases were always negative.
Yeah, usually I see it, but it's not that helpful. So I call it most likely localized variant of tenosynovial giant cell tumor.
Fletcher wrote that 44% are positive, which is bullshit. I would say 3% positive.
Okay.
I would say it's more than a few percent. But it's not very useful. So okay, so this was a subserosal nodule in the uterus of 34-year-old female. It had like 5-6 centimeters, and it was sent to me to make to call it something. The submitter thought or was asking whether this is not stump, a smooth muscle tumor of unknown biological behavior or unknown malignant potential. And I think you can see right away that this is indeed smooth muscle tumor, very pinkish cytoplasm, elongated spindle cells, and it's quite cellular, which is common in the uterus. But indeed, there are some areas where you can see some minor atypia. A lot of these seemingly atypical cells are actually endothelial cells, so you have to subtract that, but still, like this area, for example, it looks a little bit atypical. And what was most worrisome were areas here somewhere. Okay, here. So this is necrosis. So whenever you see necrosis in a uterine lesion, it's kind of alarming finding, but not always it means sarcoma. So this was a young woman, 34-year-old, and also the context was not that worrisome. Apart from some focal atypia, there was not increased mitotic activity. The nodule was well circumscribed. So the only worrisome thing was the necrosis here. So you can there are basically two types of necrosis which are recognized in uterine tumors. One is basically ischemic type necrosis, and one is tumor type or coagulative type necrosis. It's very hard to differentiate between the two, but sometimes it helps to do special stains. I find the most useful stain trichrome, and they say when it's ischemic type necrosis, you have accumulation of fibrous tissue basically, which stains with trichrome, and this is the area of necrosis, and you can clearly see it's just all blue. So this is most likely just ischemic hyaline type necrosis, not tumor necrosis. It's most likely related to hormonal changes. I also did to differentiate between benign and malignant smooth muscle neoplasms of the uterus. You can use a panel of immunostains. There's like a paper on this P53, P10, retinoblastoma, and ATRX. And whenever you see like positive type staining in these stains, it's more worrisome for malignancy. All were negative. Okay, how much time do we have? Okay, all right. So 6-year-old girl with a recurring tumor on her lower eyelid. It was called fibroma in the past, and that's what we have here. So hyalinized center and quite cellular periphery, but still in between the tumor cells, even in the periphery areas, you still have this hyaline fibrous tissue. Otherwise, the cells,
Smart.
the cells look spindled, very nice spindled, and they have eosinophilic cytoplasm, so you can guess these might be fibroblasts. So you do smooth muscle actin and of course many other stains. Everything else was negative, but SMA shows 100% cells positive. In this, they call it tram track pattern, where the staining is positive on both sides of the cell, basically of the spindle cell. So it resembles tram tracks, which is a type of staining typical for myofibroblasts. So we did also called Desmin, cytokeratins, S100, ERK, SOX10, EMA, everything was negative. And so this combination of morphology and immunophenotype with diffuse SMA positivity and this myofibroblastic morphology blend, occasional mitotic figure but no atypical mitosis and hyalinized areas is suggestive of one tumor, and that is nodular fasciitis. Again, I didn't pinpoint it, but occasionally you can find these extravasated erythrocytes here, which are typically found in nodular fasciitis. Also here. This is a little bit older lesion, and when the lesion gets older, there is more fibrotic hyalinized areas, such as seen here. I did USP6 fish. It was clearly positive. In 70% of cells, there was a break of USP6, so nodular fasciitis. Okay, 47-year-old male tumor of the spermatic cord. Just go through the slide first. It was sent as sarcoma, possibly malignant Tenosynovial giant cell tumor, which I completely understand based on morphology, because we see here sclerotic stroma, epithelioid cells in between that, but the location is completely unusual. Malignant Tenosynovial giant cell tumor would be most common in the knee or elbow or some other large joints, occasionally on the hands or feet, but not in the spermatic cord. So we see, you have these giant cells here, which is probably why they think of this tumor as well. Importantly, the non-giant cells, which are the neoplastic component, the giant cells are, again, just an accompanying population. They have quite a lot of mitoses, atypical mitoses. So it definitely looks malignant. There's some adipose tissue here, but at least in this area, I don't see anything unusual in the adipose tissue. But still, the location and age, it's just so important in soft tissue pathology as well as in bone pathology. Spermatic cord, older male, first thing, and you see something malignant. So first thing you have to think about is the differentiated liposarcoma. So I did basically just one stain. This is MDM2. You can see large subset of the cells are positive. Still, I'm kind of careful with MDM2 antibody. It has some false negatives and false positives. So unless all the tumor cells are positive, I still follow with fish. And there was MDM2 amplification.
There was?
Yes, there was. So this is the H&E of the submitting institution. It's not very nice, but So yeah, giant cells are a useful clue for some tumors, but more often you will see giant cells confusing you. So here it was just confusing factor. Some dedifferentiated liposarcomas, as well as many other malignant tumors, have giant cell component, which doesn't mean anything.
Also, inflammatory and sclerosing variants are very common at the spermatic cord.
Yes.
So if you see some spindly hypocellular lesion in the spermatic cord, which looks like something inflammatory, always think about the differentiated liposarcoma, otherwise you will miss the diagnosis.
80-90% of spermatic cord are these liposarcomas.
Yes, yes. I have an amazing case which I'll show you next week in the spermatic cord. Otherwise, yeah. Also, if you see something that looks like hormones disease or IgG4 related disease, always do NDM2 because you might have atypical cells scattered in between the inflammatory cells, so you don't notice them, and it's just inflammatory dedifferentiated liposarcoma. Okay, so.
Yeah. Michael. Oh, this is near, yeah. And here one amazing case from Slovakia. It was from Orbit. The eye was removed. By exenteration. And in the diagnosis, there is a recurring inverted Schneiderian papilloma. I do not believe that this name Schneiderian can be used in this location because Schneiderian plate is a nasal structure, but still, look at it, what's here. There is something really like papilloma. Not entirely benign, yeah. But I'm sure that every pathologist saw small papillomas arising in conjunctiva, and it looks like even just big exaggeration of the same thing. But I do not think that it's entirely benign. Look at the cellularity of it. It has mucinous mini-likes, which is seen even in those benign lesions. But look how it changes, yeah? Slow by slow, it changes into classic mucoepidermoid carcinoma. I never saw anything like that. I didn't do genetics so far because I got a case on Thursday. I will do it. I will report you about it. But you can still see here the structure from which it started, yeah? I don't know, have you seen anything like that?
I have seen the case. You showed me the.
Yeah,
but
previously,
not in the eye. This is conjunctiva, correct?
What?
The location is conjunctiva. This case.
Yeah.
I have not seen.
Probably because it's from the exentrated eye, yeah. Yeah.
It may come from the lacrimal glands.
It can, but it's still
the same tumor types in the lacrimal glands.
Yes, but the same pathology. It's not Schneiderian papilloma, yeah?
No. It's mucoepidermoid. Yeah.
We'll see. I will still play with the case, yeah.
But you've got the same tumor types in the lacrimal glands as in salivary glands. So these lesions are completely the same.
But I didn't see that even in salivary glands, anyone.
Yeah. That papillary component is strange.
This is salivary gland from our files. I just played with it, and you see the typical morphology of it, of so-called hyaline cells. It was fully as 100% substance positive. But what was nicely seen here was plaque-1 positivity, immunopositivity. So that I think it is one of those plaque-fused hyaline cell tumor of salivary glands. Actually, we should get more cases of it, yeah? By quick looking in 12 files, I found 2 cases. Another one is this one. No, it's different, sorry. I have only this one here. Then I have this case of skin. I got to consult. Where's the bug? Yeah. Yeah. The question was, is it some cysts only? Or what is it? It's double-areate peripheral myoepithelioma in it. Just there is one small knob, you can see it here.
What was the location of the lesion?
On fingers, somewhere,
Fingers, okay.
skin, yeah. And again, when you make plaque-1 staining, you see nice positivity. That means it's pleomorphic tumor of the skin or mixed tumor of the skin. And it will be some plaque fusion behind it, yeah. So that it's not just cystadenoma, it's cystic lesion in which there starts this tumor.
I believe in immunohistochemistry with plaque-1. I do not believe so much in immunohistochemistry with HMGA2, that's non-specific. But this plaque-1 seems to be quite good for pleomorphic adenomas and myoepitheliomas. The previous case, Michal, I think it was simply oncocytic type of benign myoepithelioma with plaque-1 immuno.
Fusion.
Yeah.
Fusion.
Yeah. We have such cases. That's not so rare.
Yeah. Here I have a skin lesion, and you see there is a blister, and on both sides of blister you see atypical cells. I think that H&E slide can be sufficient to call it malignant melanoma. But first you should exclude one thing, one diagnosis. It is melanoma arising in Hailey-Hailey disease.
Yeah, something.
Just clinical picture if you do. I have a reprint from last time, yeah. I will give you this report, and they describe all differential diagnoses of this lesion, yeah. So they describe, and very important is to measure the depth of the tumor. You should not count the blister to it, yeah.
But just before you make a diagnosis of Hailey-Hailey, you need clinical pathological correlation.
Yeah.
So
And
it could be more. It could be anything. Yeah.
Yeah, broader as well.
You should have more of these, yeah.
Yeah.
Not only one. Yeah. You have keratogenesis of the same lesion, yeah, so that you see nicely that.
And was the biopsy performed because of the blister?
I got it from third.
Okay.
So I don't know any clinical findings. It's third pathologist sent me. Yeah. Okay, I have here a case of skin. Which had such epithelial eosinophilic cells which were 100 azathioprotein positive. And it came to us as BAP1 deficient nevus. We did BAP1. And we found no deletion of BAP in it. We did genetics and the BAP was retained. So here, brain, prame. You see positive in all of these. So that we call it BAP1-like pigmented lesions, probably melanoma. Yeah. Yeah, tumor of the skin again. I got it with diagnosis of adnexal benign tumor. Well, there was genetically fusion of MIB, so that it's nice example of skin example of adenocystic carcinoma. In the skin, this tumor is quite indolent. Yeah, most skin and breast, these two locations have relatively very good prognosis, and maybe here it is diagnosticable even from H&E slide. Yeah. So, most important thing not to call it high-grade lesion, it is low-grade, nearly benign behaving. Here I have an ovarian lesion, beautiful ovary. Your first indifferential diagnosis would be what? Yeah, metastatic colorectal, but it is not. It was B2 negative and CDX2 negative. Yeah.
This is borderline or teratoma.
No, I think that it is. I would call it generally as mucinous borderline tumor, but in between, in some places, I must, here it is, even an H&E slide maybe to be seen. There were areas of microinvasion. It's better seen in cytokeratin staining. Yeah, here. Oh, you can see it here, yeah? These small cells. All these foci were smaller than 10 square millimeters, yeah? So that they say until when it is smaller than 10 square millimeters, it usually behaves in a benign way, yeah? But still, I would call it intestinal type of mucinous cystic tumor of borderline malignancy with foci of microinvasion.
Yeah.
It's tumor of, yeah, it's a nice case. I got it as a strange muscular hemangioma or hemangioma of lymph node. There were several nodules under the curvature of stomach. And what it is, it's ectopic spleen.
Okay. Thank you.
You can see peniculate vessels, you can see when you make gamma staining, you see that these places that look like adenomatous are just red pulp, yeah, so nicely. Okay, I think we've run out of time. See you next week. Thanks for attention.